mine at Neville Fernando Teaching Hospital. We got a patient who was 25-year-old. He's a laborer who came with a history of intermittent fevers and weight loss over few weeks. It extended beyond 4 weeks. Only significant history was that he had a past medical history of getting his mitral valve repaired. Most likely it was following a prolonged mitral valve prolapse. Detailed history revealed that he had some dental procedure. He said that the dental cleaning kind of procedure was done about 6 weeks ago. So the characteristic features in this history was a pyrexia of unknown origin, which we call in medicine prolonged fever, which has been going on for weeks' time. In association with a heart condition, an examination confirmed that there is a leaking valve still. So this combination, febrile illness with evidence of valvular lesion, gives us the tentative diagnosis of infective endocarditis until proven otherwise. So we came to this clinical diagnosis and the question came up, how should we further investigate this patient? How would we have prevented this serious illness in this man? So I'm going to answer these questions throughout my lecture. So what is infective endocarditis? It is an infection which involves the endocardial surface of the heart. Now, endocardial surface, we don't just consider the atrial surface or ventricular surface. It also includes any valve. It can affect one valve or many valves of the heart. The mural surface of the atria and ventricle. Any kind of septal defects can get affected. Most commonly ventricular septal defect. Or also we can include large intrathoracic blood vessels such as aortic root and any intracardiac prosthesis. So this includes any prosthetic valve which has been placed before, or any valve which has been repaired with prosthetic material, or any new prosthesis such as a wire of a defibrillator or a pacemaker. So those sites get infected on the surface of the cardiac, on the surface of the interior aspect of the heart, that is the endocardium. Now the question comes up, do we all develop infective endocarditis? So it's not. There are people who has high risk, especially people who carries prosthetic valve, I already mentioned that, or any intracardiac device, and people who has had previous cyanotic congenital heart disease such as Fallot's tetralogy or tricuspid atresia. These conditions are cyanotic heart diseases which get repaired during childhood, or a person who has had previous infective endocarditis. These are the categories of conditions which predisposes you most to get infective endocarditis. However, nearly 50% of cases of infective endocarditis does not have this high risk. They happen in people having normal cardiac conditions. Apart from these predisposing factors, there are some other co-associations also. They are also called as high risk categories. People with previous rheumatic heart disease, especially we are now bypassing the generations of people having chronic rheumatic heart disease due to improvement of our general sanitation. However, still there are people who are suffering from chronic rheumatic heart disease. Now, degenerative valves becoming more common because prolongation of the life expectancy. People living above 65 years is increasing. So more and more people will be diagnosed with degenerative heart disease, especially aortic sclerosis or myxomatous mitral valves, while these rheumatic heart conditions are coming down in the community. Then more and more hemodialysis is encountered in our community because of improvement of services towards kidney disease, and also more and more diabetes because we are not caring of our lifestyle. So all these are increasing. There is an increasing trend, and HIV is increasing, and IV drug abuse users are also increasing in number. So even though the tendency of chronic rheumatic heart disease is coming down, the tendency of all the other risk factors are increasing. So with this background, let's look at the prevalence. So prevalence in the community, we haven't got specific idea or more precise idea about our own prevalence in a developing country. However, annual incidence of infective endocarditis is about 3 to 9 cases per year per 100,000 population in industrialist countries. This figure is definitely high among us in Southeast Asia and all the other developing countries. Now, when you take male to female preponderance, the ratio is exceeding 2 to 1. It is also noted that the incidence is increasing above people more than 65 years of age. The reason, I think you all already noticed, the tendencies of long living is experienced by us. Now this figure shows this. Earlier, the infective endocarditis is more predominantly seen in middle age, 25 to 40 years age group. Now it is more towards more than 65 years age group because of increasing life expectancy and more conditions of adulthood as recognized as most predisposing factors. So it is the coexistence of many factors which I mentioned in the previous slide. Now let's look at the source of infection. In broad, we can divide this source of infection into two categories. Infections acquired through normal mucosal organisms. So we acquire infective endocarditis generating organisms from oral mucosa, intestinal mucosa, skin and perineal area. The second category is nosocomial organisms, especially people who undergo invasive procedures such as intravenous catheterization, total parenteral nutrition therapy, or any cardiac device insertion procedures. These causes high incidence of nosocomial acquired infective endocarditis in the community. Now, since the medical procedures and interventions are increasing in number among us, we are coming across more and more nosocomial organisms also causing infective endocarditis. Now, if we take these common organisms of normal mucosal surfaces, this is the distribution. Now, I think from the dental surgeon's point of view, the most important organisms are from oral cavity. So, Streptococcus viridans was the most common agent for infective endocarditis in the past. Now it has changed. Now we are coming across more cases of Staphylococcus aureus that overriding Streptococcus viridans. So Staph aureus comes mainly from the sites such as superficial skin or nosocomial acquired root. And gut and perineum also plays an important role, especially Enterococcus faecalis enters through the gut. It grows in the gut mucosa, and if there is a lesion in the gut, it automatically enters the circulation through the open lesion. Enterococcus bovis is an organism found in the gut again, The importance of this organism is it is associated with gut malignancies. In the environment of gut malignancy, this bacteria overgrow and it get entered into the circulation. Among the nosocomial infections, Candida albicans also entering into our organism list, because more and more diabetics are there, alcoholics are there, all immunosuppressed individuals, and we are treating many individuals nowadays with immunosuppressive therapies. So those people are more prone to get Candida albicans as well. Now let's look at microbiological prevalence. Now when you take, I may already mention, when you take overall, in general, overall organisms which cause infective endocarditis, if you put together streptococci and staphylococci, that accounts for nearly 80% of cases. Now you can see the staphylococci and streptococci again, if you take Streptococcus viridans, accounts for about 16% out of the half of nearly 40% in total. And also if you take Staphylococcus staph aureus, account for nearly 20% of cases. Those areas are the main importance when you consider the organisms. What you should generally know is streptococci and staphylococci override all the other organisms. But at the same time, you should also remember that this proportion varies according to the type of valve as well. So if you take native valves, most commonly it is viridans streptococci. But if you take prosthetic valves, that the endocarditis on a prosthetic valve is mostly likely to be staphylococci. Source of infection, again important, I already mentioned sites of origin of the infections, and with patients' age also, drug abusing patient, intravenous drug users, so staphylococcus become the most likely organism. Then coexisting conditions such as gut malignancy, Enterococcus bovis is the most likely organism. So organism prevalence also vary according to individuals' coexisting comorbidities. So these points has to be considered when you are dealing with the infective endocarditis suspected patient. So further about the microbiology. Now we talk about 80% responsibility of staphylococci and streptococci. However, about 10% will become blood culture negative. Now blood culture negative infective endocarditis is another entity. The most likely explanation for negative blood culture results in an infective endocarditis diagnosed patient would be either previous exposure of antibiotics, because you can't grow the bacteria anymore because partially treated with antibiotics, or else the organisms the responsible for the condition would be more fastidious and difficult to grow on normal culture media. So such as Bartonella, Brucella and Coxiella will not grow in normal blood culture media. Other than this, there are slow growing organisms also, which we refer to as Hackett organisms. These Hackett organisms are actually normal flora in our oropharyngeal passage. They are very slow growing. Because of that, we miss their growth in the even in the normal media. Haemophilus species, Aggregatobacter, Cardiobacterium, Eikenella and Kinella are these 5 organisms which has slow growing capacity. Apart from that, Trophirema vipilli is another very rare organism which we will not be able to identify by normal microbiological studies. Let's look at dental health and endocarditis. I think I should not talk much about it, you know better than me. Now, out of the oral organisms I mentioned, in the oral cavity we come across streptococci, lactobacilli, staphylococci, corynebacteria and various other anaerobes such as bacteroids. So they are all normal organisms. Now, oral bacteria is very important when we talk about endocarditis of high risk people, which I already mentioned, such as people having prostatic valve disease, corrected cyanotic heart disease. In developing countries, infective endocarditis due to oral organisms account for about 1/3 to 2/3 of cases. However, we should remember that the endocarditis resulting from dental procedures alone, the number is very less. So this has been highly actually discussed broadly when they prepare recent most guidelines for treatment and prevention of infective endocarditis in relation to dental procedures. This how do we induce infective endocarditis after a dental procedure? Now, usual bacteria found in the tooth plaque multiply within the tooth plaque and cause gingivitis. Now, if someone is having ongoing chronic gingivitis, the gum tend to bleed even with a simple brushing. So, after repeated and recurrent irritation due to the on and off intermittent bleeding, the growing organisms enter the bloodstream. So they free float in the bloodstream and enter the circulation looking for a site to adhere. Now, if someone is having a high risk or abnormal endocardium due to a lesion like a valvular lesion or some prosthetic material attached to the surface of the endocardium, this bacteria go and lodge on those sites. And apart from getting lodged during the circulation, they have some properties to adhere also, adhesive properties to adhere to the endocardium. So once they adhere, they multiply on those sites, forming pockets of bacteria, which lately leads to vegetation formation. So that is the development of endocarditis, which carry organisms from the oral mucosa. So same way, from any other side, whatever the bacteria enter, it go and deposit with their adhesive properties on damaged endothelium and tend to grow on those sites. Once they grow into polypoidal masses, they tend to shed those organisms from those vegetations to other sites. That is what naturally happens in infective endocarditis. So, some other important points also related to pathophysiology are the blood flow irregularities also play a main role. For example, jet lesions are generated when there is abnormal blood flow. Our blood flow is usually a laminar flow which flows smoothly. But if there is any narrowing or abnormal shooting, imagine if you have a ventricular septal defect, blood shoots from one side to the other side. So this jet flow go and make endothelial damage on the opposite side of the ventricle. So this continuous jet flow tend to form an abnormal endothelial surface where bacteria can go and deposit with its adhesive properties. And also intravenous drug users use some particulate matter with their injection. So some of these particles also known to cause endothelial damage, which trigger growth of bacteria on those sites. Now let's look at clinical features. The commonest clinical feature is febrile illness. More than 38 degrees of Celsius is very significant. They may have intermittent pattern to this fever. It is not very continuous high grade fever. They feel better at times without fever, again develop fever spikes. That's the characteristic fever pattern in infective endocarditis. Then with the development of vegetations, there can be the vegetation development on the valve surface as well as the chordae tendineae, which regulate the valve closure and opening. So when the chordae get damaged due to vegetation growth, there can be either development of a new murmur, or patient can have variation of the murmur already existing. So if someone is having mitral stenosis, later on it can progress into mitral regurgitation due to the damage of the chordae tendineae. So that because of this reason, infective endocarditis patient should be examined every day, because first day it may be one murmur, the next day it will be a different murmur. Hematuria developed due to glomerulonephritis. This happens due to immunological mechanism, because once the bacteria is generated in the body, body immunity make antibodies. So antigen reaction release more and more immunoglobulins in the circulation, which go and attack the kidneys, resulting in hematuria. Splenomegaly is well known again, and splinter hemorrhages and Janeway lesions and conjunctival hemorrhages. These three are again called vascular phenomenon of infective endocarditis. Once the circulation has infected material, the vascular reactions occur in different sites. One thing is due to formation of mycotic aneurysms, other thing is dislodging of the infected material into other sites. Rot spots, I will show some pictures of those. Rot spots, again an interesting and characteristic finding which we see inside the eye through the ophthalmoscope. It is a immunological feature which occur due to infective endocarditis. Osler's nodes are another characteristic feature of infective endocarditis. They are painful, elevated nodular lesions seen on the skin, especially on the surface of the hand. So here you can see the point is not working. That's okay. You can see the Osler's node, which is very painful. This is an elevated node. It is an immunological reaction, immune deposition on sites, different vascular areas generate these nodes. And this is called a Janeway lesion. It's a reddish flame-shaped patch. Mainly you see thinner and hypothinner eminences of the hand. Splinter hemorrhages are vascular irritations or vascular lesions. Streaky lesions you will see either on the nail bed or nail fold. Even you can see them in the eyes. This is the rot spot. The center is white and there is a surrounding erythematous border. So this is an immunological feature of immunological development of endocarditis. And apart from that, conjunctival hemorrhages also can be seen in infective endocarditis. Now, apart from these classic clinical features, some other clinical features also will be encountered due to development of complications related to infective endocarditis. So what are these complications? Patients will go to severe sepsis because its circulation of bacteria in the body leads to sepsis, resulting in hypotension, confusion, and even They can leads to meningitis because it's blood-borne infection in the body. It can go and dislodge, infect any other organ of the body. Unexpected heart failure occur due to valvular leakage or damage to myocardium. Septic pulmonary emboli occur due to right-sided infective endocarditis. When the right-sided valves are involved, these septic material go and enter into the pulmonary circulation, and it can even give rise to multiple lung abscesses. The most serious and more commonly encountered complication is cerebral complications such as transient ischemic attacks, strokes, myotic aneurysms resulting in bleeding in the brain, or formation of brain abscess resulting in weakness of a side of the body. Apart from that, left-sided infective endocarditis due to dislodgement of vegetations, acute peripheral arterial occlusion, limb ischemia, ischemia of the bowels can happen. Even renal failure can happen due to acute glomerulonephritis or due to sepsis. Now, how do we diagnose this? The diagnosis is based on clinical findings, which I have explained already, then microbiological confirmation and echocardiographic findings. All these three components are put together under modified Duke's criteria to make the diagnosis a definite diagnosis or likely diagnosis or unlikely diagnosis depending on the presence of this criteria. So under modified Duke's criteria, we have pathological criteria, clinical criteria. So there are two pathological criteria. I will be describing it later, and there are 5 major clinical criteria. So either presence of one pathological criteria, you can make a definitive diagnosis, or presence of 2 major clinical criteria, we can make the definitive diagnosis, or combination of 1 major and 3 minor or 5 minor criteria make the definitive diagnosis. And this modifies Duke criteria, which combines clinical, microbiological and echocardiography findings, has a sensitivity and specificity of diagnosing infective endocarditis in more than 80% of people. And the point we have to remember is, even though the Duke criteria helps us to diagnose this more sensitively and specifically, the clinical judgment always overrides. If you are suspecting, you have to treat it as on the clinical basis. You have to treat it as infective endocarditis. Now let's look at microbiological diagnosis. What are the things we do? Most importantly, it is blood cultures. At least or minimum of 2 cultures, or best is taking 3 sets of blood cultures. You can take these 3 sets of blood cultures within 30 minutes, but from 3 different sites. It will give higher achievement of catching the bacteria when the culture is grown. So 90% sensitivity can be expected if we take 3 sets of blood cultures. Apart from that, certain organisms can be diagnosed with the help of serological testing, such as Bartonella, Coxiella burnetii and Brucella. Histological diagnosis also can be achieved by taking samples of vegetations if the patient been operated, or if there's any mycotic aneurysms being opened up, we can take samples of vegetation dislodged to use for cultures and histology. PCR technique and immunostaining are also important, and they are helpful to diagnose the organisms, especially when the organisms are not cultured, But when we suspect more fastidious organisms, these methods are being also used. Now, how do we confirm the endocardial involvement? It is mainly based on the echocardiographic findings. Commonly used echocardiographic technique is transthoracic echocardiogram. Now, the sensitivity of transthoracic echocardiogram is always doubtful. If you see the vegetation, it confirms, but if you can't see the vegetation, it will not exclude infective endocarditis. Because of that, we have to go for transesophageal echocardiography, especially when there is high clinical suspicion or either poor imaging quality, may be due to the obesity, or in females the visualization will be difficult, or if there is a prosthetic valve, you will not be able to clearly see through the transthoracic images. These situations will be using transesophageal echocardiography after transthoracic echocardiography findings. Now, what do we see on echo? We will be visualizing vegetations which are mobile sessile masses attached to either a valve, a prosthetic valve, or endocardial surface, or maybe to a chordae tendineae, the apparatus which regulate the valve function. There can be paravalvular abscess formation that also can be visualized, or dehiscence of any prosthesis material which has been placed before in the heart, formation of pseudoaneurysms, and even formation of fistulae between two sides will be seen, which can happen after episode of endocarditis. Now let's look back again at Duke's criteria. This is the two pathological criteria. Either one of these will direct us towards definitive diagnosis. So microorganisms identified by either culture or histological examination of a vegetation, or from a vegetation that has embolized, or from intracardiac abscess specimen taken at a time of a cardiac surgery. The second criterion is confirmation of active endocarditis with a histological examination of a vegetation or an endocardial abscess. So any one of these will confirm a definitive diagnosis. When you take major clinical criteria, both should be there to call it a definitive diagnosis. Positive blood cultures in 2 collected samples, or echocardiographic evidence of presence of vegetations, or a new valve regurgitation will confirm definitive diagnosis. So both criteria should be present together. When we move on to minor clinical criteria, all 5 minor clinical criteria should be present to call without either pathological or major criteria. So predisposing conditions, we already discussed that. Predisposing heart condition or intravenous drug usage, febrile illness exceeding more than 38 degrees centigrade, evidence of vascular phenomenon such as major arterial emboli, pulmonary infarction, mycotic aneurysms, etc., or immunological phenomenon, evidence of glomerulonephritis, Osler's nodes, rot spots, and in here you get false rheumatoid factor positivity. So that is again an immunological phenomenon. Then microbiological evidence of positive blood culture. Here we take positive single blood culture because we have already taken 2 positive blood cultures as a major criteria, or any other serological evidence or immune staining evidence to prove a microbiological organism. So when it comes to possible diagnosis, this is the combination: clinical criteria, 1 major or 1 minor criteria, or 3 minor criteria taken as possible infective endocarditis case. Now I will take back again to the old days. The classification of infective endocarditis in the past was acute, subacute, and chronic. So acute endocarditis we considered as caused within a given short period and most likely due to Staphylococcus aureus. And subacute and chronic forms can be going on for a given period of time, and most likely the more innocent organisms such as Strep viridans. Now this classification is outdated. We classify the infective endocarditis according to the cardiac condition, the location, whether it's mitral valve, tricuspid valve, or right-sided endocarditis or left-sided endocarditis, whether it is on an endocardiac device or prosthesis, and also considering mode of acquisition like nosocomial or acquired from normal mucosal flora. So this is a very broad classification. Because of this broad classification, the condition classification will overlap. So we might call left-sided mitral valve infective endocarditis acquired through the hospital infection. So it is a more longer description. So what is the outcome? So in hospital mortality ranges from 15 to 22%, while 5-year mortality due to the valve damage and cardiac damage goes up to 40%. The mortality is lesser than 10% if it is a right-sided lesion and organism is more innocent like oral streptococci, or if it is left side, a native valve. More disastrous outcome will be encountered if the infective endocarditis is on a prosthetic valve and if it is associated with Staphylococcus aureus. In general, these are the situations where we encounter more worse outcome, higher the age, Staph aureus infection, coexisting heart failure, complications such as cerebrovascular accidents or any other embolic event, or if it is healthcare associated infection. Now, how do we treat? Appropriate antibiotic treatment has to be started immediately on suspicion. So we have to follow the guidelines, and these guidelines will indicate the route, dose, frequency and the maximum duration of treatment. So bactericidal antibiotics are required for a longer period. That is the main treatment modality. Apart from the antibiotic therapy, surgery has a place as well to remove larger sessile masses which has a tendency to dislodge and result in more complications. Or if there is abscess formation, without draining the abscess you can't cure endocarditis. Sometimes there can be severe paravalvular leaks which need to be repaired, otherwise patient will go into heart failure and encounter more serious complications. So let's look at antibiotic therapy. I'm going to just highlight the most important points. Now antibiotics are decided on these factors. First of all, we have to decide whether it's a native valve or a prosthetic valve. If it is a prosthetic valve, whether it is less than 12 years placement or more than 12 years. If it is a more than 12 months placement, that considered as a native valve again. Then we have to consider if this patient has penicillin sensitivity or not. So those are the basic rules to decide on empirical antibiotic therapy. So if the patient has got native valve, we will treat with amoxicillin clavulanic acid high doses divided into 4 doses throughout the day. So it should be given according to the clock. This has to be combined with gentamicin, again high doses, 3 mg per kg per day divided in 2 or 3 doses. Native valve endocarditis the rough time period for therapy is 4 to 6 weeks. If the patient has beta-lactam intolerance or sensitivity, where we don't have any other option other than using vancomycin together with gentamicin and ciprofloxacin, This is the current treatment guideline. Again, the treatment duration is 4 to 6 weeks. We have to use high doses. Empirical treatment for prosthetic valve is similar to treatment of penicillin sensitive or intolerant patient, except we use rifampicin in the place of ciprofloxacin. Prosthetic valves more than 12 months post surgery is treated as native valve. So this is empirical treatment regime. Now antibiotics in general, if you take for native valves, even though I mentioned it is 4 to 6 weeks, nowadays there is another tendency. We can discontinue treatment after 2 weeks if the organism is recognized as strep viridans and the beta-lactam sensitivity is proven and there is no major complications. With this background, we can discontinue after 2 weeks therapy. But when it comes to prosthetic valve, it is either 6 weeks or more, depending on the prosthetic valve and circumferential complications. Always therapy should be given as intravenous and there is no place for oral therapy. We consider the day of starting therapy on the day that we use the appropriate guideline recommended therapy, not using various regimes and finally coming to the guideline recommended therapy. So it is should be considered as the first day with the initiation of appropriate recommended therapy. Now there is slight deviation when you come across or isolate the organism. So if you isolate the organism as Staphylococcus aureus, we encounter two situations. It may be methicillin sensitive Staphylococcus or methicillin resistant. If it is methicillin sensitive, we can go with cloxacillin and gentamicin. Here cloxacillin given for 4 to 6 weeks, while gentamicin IV in 2 days for only 3 days once you isolate. Patients with methicillin resistant Staph aureus or penicillin allergy, vancomycin is the treatment which should be continued. So this is the continuation once you isolate the organism. If it is a prosthetic valve, rifampicin has to be always continued. Surgical treatment is recommended, especially in following situations. If there is heart failure, the infection cannot be controlled either due to development of paravalvular abscess or when it is when there is impending possibility of embolic events due to large sessile growths. Now, how do we prevent infective endocarditis? So it is very important to maintain, because most of the organisms are acquired through mucosal surfaces. Keeping mucosal surfaces under good hygienic conditions is very important. There is no major increase in the incidence of infective endocarditis due to viridans streptococci, especially in relation to dental procedures. So therefore, today antibiotic regimes are only recommended, antibiotic prophylaxis are only recommended before special dental procedures for given conditions, which we consider as high risk for infective endocarditis. So these are the indications for antibiotic prophylaxis for dental procedures. If there is a prosthetic valve or heart valve repaired with any prosthetic material, if a patient has previous infective endocarditis history, if patient has had a heart transplantation with the abnormal valve, or if patient has had any congenital heart defect which is under the category of cyanotic congenital heart disease, or any heart defect repaired with another prosthetic material, or patient has got placed any cardiac device and previously repaired heart disease with known continuing abnormality. So these are the situations that we use prophylactic antibiotics for dental procedures. So what are we using for as prophylaxis? So mainly the prophylaxis is aimed at strep viridans. It is given as a single dose 30 to 60 minutes before the procedure. So standard, again the therapy is determined whether patient has penicillin allergy or not, tolerance or intolerance. So mainly the agent what we use is amoxicillin, 2 grams high dose given as a stud dose before 30 to 60 minutes of the procedure. If patient can't take anything orally, then we have to go for intravenous therapy using ampicillin 2 grams. Anybody who is allergic or intolerant of penicillin, we have to prescribe oral clindamycin 600 milligrams. Usual dose is 300, 600 milligrams to take as a stack dose orally, or if can't take orally, it is clindamycin intravenously 600 milligrams. Now, there are certain dental procedures people debate about either to give or not to give. So this is the current recommendation. Dental procedures or conditions that do not require prophylactic therapy are routine anesthetic injection through non-infected tissue, taking any dental radiographs, placement or removal of any prosthodontic or orthodontic appliances, adjustment of orthodontic appliances, placement of any orthodontic brackets, shedding of deciduous teeth, or any gum or lip bleeding conditions. So here we should not actually consider any antibiotic prophylaxis unless patient is not having any high risk predisposition factor. Now let's look at my patient again. Now this patient, we did initial blood cultures. We only managed to take 2 blood cultures. Both blood cultures became positive for Streptococcus viridans. And the transthoracic echocardiogram only revealed valve leak and could not recognize any vegetations, but transesophageal echocardiogram confirmed that there were a couple of vegetations on the posterior mitral valve. So we confirmed the diagnosis with 2 major clinical criteria, and the diagnosis of mitral valve infective endocarditis in the background of repaired valve is made. So you got the new classification is more complicated. We are not calling acute or subacute nowadays. We started on empirical antibiotics using ampicillin and gentamicin. After the 3 blood cultures, we continued both for 4 weeks. Patient actually, we had to transfer to NHSL because my hospital is unfortunately a private hospital. So patient could not afford long stay of that duration. We had to transfer to cardiology unit. So still he should be in the cardiology unit receiving the treatment. Now key points which I try to highlight here is nearly 80% of cases of infective endocarditis are due to staphylococci and streptococci. Staphylococci are becoming the most common pathogen. Cerebral complications are the most frequent and most serious extravascular cardiovascular complications, and the risk of symptomatic embolization is more when the vegetations are larger, mobile, and in the mitral position, and if it is due to Staph aureus. Identifying the causative microorganism with the microbiological cultures and other methods are very important by at least doing 2 or 3 blood cultures. Empirical antibiotics should be started with the immediate suspicion, and echocardiography should be followed to confirm the diagnosis. Surgery has a place if there is heart failure, uncontrolled infection, or risk of embolization. And the infective endocarditis is not only a physician task, it's a multidisciplinary task which involve cardiologists, cardiac surgery, infectious disease, and I haven't forgotten that dental surgeons as well. So even though I haven't put it here because this is the treatment aspect, but prevention aspect, you all have a big role when there is an indication. Antibiotic prophylaxis is restricted to invasive dental procedures in patients who have prosthetic valve, history of infective endocarditis, or unrepaired congenital heart disease, or any other prosthetic material. So my lecture is based on these references, and I have provided them for your reference as well. And I brought you along the way in case of infective endocarditis. So thank you so much for your patient hearing, and I thank once again to the College of Dental Surgeons for giving me this opportunity to deliver this lecture to you. Thank you.